Priyanka ma'am, can we start?
Yes, we should.
Okay. Good evening, everyone. I feel extremely glad to welcome everyone to this blockbuster series on high risk obstetrics by NIMA OBGY Society Central Body. Myself, Dr. Archana Pandey Jumle, will be coordinating today's webinar with Dr. Aarti Nadar. Before starting our session, I would like to request all the dignitaries and all the participants to take a moment for the blessings of Lord Dhanvantri. May I request Dr. Aarti to proceed with the Dhanvantri Stavan.
नमामि धन्वन्तरिमादिदेवं सुरासुरैर्वन्दितपादपद्मं लोके जरारुग्भयमृत्युनाशनं दातारमीशं विविधौषधीनां शङ्खं चक्रं जलोकां ददमृतघटं चारुतोभिश्चतुर्भिः सूक्ष्मस्वच्छादिरुत्यां सुखपरिविलसन् मौलिमङ्गोजनिद्रां कालाम्बोधोज्ज्वलाङ्गं कटितटविलसच्चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवनं प्रौढदावाग्निनीलम्.
Thank you, Dr. Aarti. May Lord Dhanvantri bless us all with good health. Let us continue and begin with today's webinar. Before that, I would like to give a few instructions. I would like to request all the delegates to kindly keep your phone on muted mode, and if any queries, kindly put all your queries and your questions in the chat box. Proceeding further, today we all are honored to have with us very eminent speaker, respected Dr. Chaitanya Shivdega sir. Sir is founder, chairman, and MD at Omega Hospitals Private Limited. Sir has very vast experience, but will be summarizing in short. Sir, being a very efficient pelvic and endoscopic surgeon, is a great speaker as well. Sir is past president of Nagpur OBGY Society. Sir is member of PCP&DD Committee, Nagpur Municipal Corporation. Sir is chairman, Infertility Committee and Emergency Obstetric Committee, AMOGS. Sir is recipient of Kamini Rao Yuva Foxy Oration Award, Dr. Kumud Tamaskar Oration Award, President Oration, NOGS. Sir is recipient of prestigious Dronacharya Award by ISAR 2024. Sir has received MS Signature Award 2021 at the hands of Honorable Sri Nitinji Gadkari. AMOGS Best Committee Chairperson Award at the hands of Honorable ex-Governor Padma Shri Dr. D.Y. Patil. Sir has many more awards to his credit, such as AMOGS B43 Award for the best work in the field of infertility. Sir is guide and mentor for MUHS and ICOG post-PG fellowships at Omega Hospitals in reproductive medicine, endoscopy, and fetal medicine. So we are extremely honored to have you us on our platform. I would like to request respected Dr. Chaitanya Shivdega sir to start this presentation.
Thank you so much.
Dr. Archana. Good evening, sir. This is Dr. Priyanka.
Yes, just a second. I would like to introduce our National Secretary of NIMA OBGY. Sir, Dr. Priyanka ma'am is here with us. She is our National Secretary of NIMA OBGY Society Central Body. Sir is ma'am is director of Nakade Hospital. Ma'am is also endoscopic surgeon, laparoscopic surgeon. She is our National Secretary, sir. Dr. Priyanka ma'am.
I just want to thank Dr. Shembekar, sir. We are fortunate that we have you, sir. This is the second time on the NIMA OBGY webinar series. And truly, it's amazing and first experience with you as a guest speaker. We are having you. So, and on this topic, RP especially, considering the etiological various factors and their managements. So it's again going to be a very, very interesting webinar today. So thank you so much, sir, for giving us that precious time. Thank you. And you can continue, sir.
Dr. Priyanka. So I'll start sharing my screen. The topic which we are going to discuss today is recurrent pregnancy loss and obstetrician's perspective. I bring greetings from Nagpur OBGY Society, Nagpur NOGS. Then I bring ratings from Omega Hospitals. And my special thanks to Dr. Archana Zumbre. She has worked with me, and I know how dedicated and sincere she is, and she is also a very good clinician. Then thanks to Dr. Aarti, Dr. Kamini, Dr. Priyanka, Dr. Vishnu, and Dr. Rajan for giving me this wonderful opportunity. As Dr. Priyanka has rightly said, this is the second time that I am sharing platform with you all, and it is really a very I am really fortunate to get this opportunity, and it is really a wonderful uh, opportunity to interact with you because you all are such a lovely and receptive audience. Now, actually, today what I'm going to discuss is the classic and cutting edge strategies for the management of recurrent pregnancy loss. And today's discussion will be actually around the guidelines which the European Society has given for the clinicians to follow. But then we will not be strictly following what the guidelines say because there is something called as clinical acumen and there is something called as clinical experience. And we have to balance between the guidelines and our clinical experience. So, as we all know, recurrent pregnancy loss is a profound personal tragedy to couples seeking parenthood. It is a formidable challenge to their physicians and doctors, we all as well, because we all are really uh, frustrated the way patient comes to us with recurrent abortions and when to evaluate and what is the complete evaluation is even at the time of delivering this talk today is in a state of flux. So we really don't know how to go ahead, and that is the reason why we all are here to actually uh, discuss the line of action and basically the flow of the examination, investigations, treatment, and the approach towards a patient of RPL. Now, if you just look at the clinical situations, whenever you are sitting in the OPD and consulting in the OPD with patients coming to you will realize that there are two situations in which the recurrent pregnancy loss patients come to you. One is the situation where the patient comes to you with the ultrasound report and the report says that it's a missed abortion. She is very anxious because this is her third abortion. And in that situation, you have to counsel her, you have to do her grief counseling, and also this is the opportunity where you can actually post her for evacuation. So you have to, because if it is a 9 weeks pregnancy, then you have to post her for evacuation or abortion. There is a second situation where the patient comes to you for a regular checkup or a regular consultation. She is not pregnant, but she comes to you because she has a classical history of recurrent abortions. And here you have to start the evaluation of the patient. So the situations, now you understand there are two situations. One situation is where the patient comes with a pregnancy and you have an opportunity to actually find out what is the cause by doing her abortion or evacuation. And second is a situation where the patient is not pregnant but is coming to you with history of recurrent abortions. Now, in the first situation, the patient comes to you and suppose this is her second abortion or, as I said, third abortion. Then what will you do? The first thing you have to do is post her for evacuation. And when you post her for evacuation, you have to you have to do the karyotyping of products of conception. Remember this, friends. This is a first step. Now, why do we do karyotyping? Because you will get three types of results in karyotyping. One is a normal report. Suppose you do karyotyping of products of conception, and the report says that it is a euploid karyotype, and there is no problem. So you are sure that there is no chromosome problem. You start a RPL workup. You do go for the other investigations. Second situation, you get a report which is aneuploidy. Aneuploidy means what? There is a numerical problem like trisomy 21 or trisomy 18 or trisomy 16, some numerical problem. Now remember, friends, if there's a numerical problem, then usually this problem does not recur. So ideally, we should not do anything. No need to do investigations of partners also, and no need to do anything for this patient. But you can always talk about the PGT. What is PGT? Pre-implantation genetic testing, something which we regularly do in IVF cycles, where we test the embryo before putting it inside the uterus. That is pre-implantation genetic testing. But it is actually not indicated. You can tell them that this is something which you can do, but it is not required. Third situation. In the third situation, you get the chromosomal problems, and the problem is not numerical problem, it's a structural problem. So there is a inversion or there is a translocation. Now, if suppose the report is translocation or inversion, then what you are supposed to do, you have to do the parental karyotyping. Husband and wife both should be posted or given the advice the test of chromosomal analysis. And also you have to take the opinion of genetic counselor. You should refer the patient to genetic counselor. Genetic counselor or geneticist is the person who will actually counsel them and also guide us as to how to go ahead with this situation. But friends, this is a situation where PGT is the best option. What is PGT? Pre-implantation genetic testing. The testing which we do before we transfer the patient's embryo into the uterus in the IVF cycles. So guidelines clearly say that you should do chromosomal analysis of POCs. And what are the various types of tests which are available? One is a simple chromosomal analysis, which is good, but not very good. Why not very good? Because it does not give you the detailed answer to your question that where is the problem. So the best test is microarray with DNA storage. So what is the test which you should do? You should do microarray testing with DNA storage. And later on, you should also do parental karyotyping, where you do husband and wife chromosome analysis. And one more test you should do is Y chromosome microdeletion of husband. Y chromosome microdeletion of husband is a test which will give you idea about whether there is a problem with the Y chromosome, which may result in recurrent abortions or infertility. So just try to understand this. You need not go into details because even I don't know much of genetics. So I know only the approach. I am not a geneticist. I don't understand genetics. But I understand one thing, that you should do this test. And when you do this test, then you actually know how to go ahead. You get the direction. तुम्हाला दिशा मिळते की समोर कसं जायचं. And for this to get the direction, you should get the chromosomal analysis done of the POCs. What is the definition of RPL? RPL is recurrent pregnancy loss, and it is defined as 2 or more abortions. Actually, initially the definition was 3 or more abortions. But then one thing is every pregnancy is precious. And second thing is they realize that after second abortion, the chances of recurrence are 29%. And after third abortion, the chances of recurrence are 31%. So there is no much difference. And that is the reason why the definitions now change. And now the definition says 2 or more abortions. But friends, I would like to tell you one more thing. Suppose you all are doctors. Suppose a doctor patient comes to you, or a patient who is highly educated comes to you. She is, say, IT professional, or say she is a bureaucrat, and she is extremely busy. And she decides to have a pregnancy at the age of 32 or at the age of 34 or at the age of 35. Now in this situation, her first pregnancy, she develops abortion or she lands up in abortion. This is a situation where every pregnancy is precious. And therefore, one more school of thought or one more thing which I have started doing nowadays is, why not offer them investigations even after the first abortion? Because you don't have time. You are already 35. You have planned your pregnancy quite late. You are high profile person. You don't have time. You are bureaucrat, or you are a IS officer, or you are a doctor who is with a very busy practice. Then in that situation, why to wait for second abortion? Even you can start doing investigations after first abortion. But guidelines do not say that. Guidelines say that you should do investigations after 2 abortions. After first abortion, there is no need to do any test, because one abortion is quite common. 20% to 30% of the patients, they will have abortion. So one abortion is not a problem, but guidelines say that after 2 abortions, start evaluating the patients. And I think that if you have a situation like what I have discussed with you, then you can also tell them that the guidelines असं म्हणतात की 2 abortion नंतर करायला पाहिजे. तुम्हाला वाटत असेल तर आपण टेस्ट करून पाहू. कारण टेस्ट करण्यामध्ये नुकसान काही नाही आहे. आपल्याला जर लवकर प्रॉब्लेम समजला तर आपल्याला फायदाच आहे आणि आपण ट्रीटमेंट करू शकतो. सो दॅट इज हाऊ यू कॅन काउन्सिल युअर पेशंट्स. नो व्हॉट आर द कॉजेस ऑफ रिकरंट अबॉर्शन्स. Remember, there are genetic causes, there are infectious causes, there are endocrinological causes, there are environmental causes like smoking or pollution or alcohol consumption. There are immunological causes, there are anatomical causes like biconate uterus or diadelphys uterus. But 40 to 50% of the patients, the cause is not known. That means 40 to 50% patients are of unknown etiology, idiopathic. And that is the most important point. दॅट आरपीएल मध्ये पुष्कळदा तुम्हाला कारण शेवटपर्यंत समजतच नाही. यू डोंट नो व्हॉट इज द प्रॉब्लेम अँड देन यू आर रिअली फ्रस्ट्रेटेड. सो हाऊ डू यू गो हेड? नाऊ आय एम गोइंग टू टेल यू द अप्रोच. द पेशंट कम्स टू यू. शी सेज दॅट माझे 2 अबॉर्शन झालेले आहेत. डॉक्टर, प्लीज हेल्प मी, डू समथिंग फॉर मी. टू टेक द हिस्ट्री. If you take proper history, that history is going to give you idea about many things. Like suppose the patient says that माझे प्रत्येक वेळेस सेकंड ट्रायमिस्टर पेनलेस अबॉर्शन झाले. सो शी सेज देर आर सेकंड ट्रायमिस्टर पेनलेस अबॉर्शन. क्लासिकल हिस्ट्री. यू तुमची ट्यूबलाइट इकडे पेटते की येस दिस इज प्रॉब्लेमली इनकॉम्पिटेंट ऑस सर्वायकल प्रॉब्लेम or incompetent os is the cause of this recurrent second trimester painless abortions. Now suppose the patient says that I am having history of DVT. मला 5 वर्षापूर्वी डीव्हीटी झालं होतं. सो डीव्हीटी, डीप वेन थ्रोम्बोसिस. हिस्ट्री ऑफ डीप वेन थ्रोम्बोसिस, you start thinking that probably thrombosis or thrombotic element is the cause of abortion. So there is some clotting in the blood, and this thrombosis or clotting in the blood is responsible for DVT, and the same clotting in the blood is responsible for abortions in this patient. So this is how the history is going to give you idea about what is the cause. Then you do proper examination of the patient. And the most important thing is ultrasound. You have to do ultrasound in this patient because ultrasound will give you idea about the structure of the uterus. And which ultrasound you will do? You have to do 3D ultrasound. 2D ultrasound is of no use. Friends, it is a 3D ultrasound which will give you the exact idea about whether there is a septate uterus or a diadelphys uterus or a biconate uterus. Then you do testing. What are the investigations you should do? Basic investigations. Like CBC, you do thyroid, you must do. You must do sugar test. You must do hemoglobin test. So basic test you do. After doing basic test, the most important test which you all must do in patients of RPL is APLA testing. And in APLA, there are 3 tests. I will tell you this test. But remember friends, APLA testing is important. Then I am very sure that you gynecologist, you are working as a gynecologist, and if you are a lady gynecologist, then you tend to ignore the male partner. And remember friends, you should never ignore a male partner because there is a possibility that the problem lies in the male partner. And nowadays, the problem in the male partners is increasing day by day. And पहिले जेव्हा आम्ही कॉलेजमध्ये होतो, I remember 1992, when I joined MD Gynec, I was taught that 30% patients it is male factor, 70% it is female factor. And now the things have changed. Now it is said that 50 to 60% it is male partner and 40 to 50% is female partner. So see how the male factor is becoming a major cause of infertility and abortions, and therefore you must do proper evaluation of the male partner. We all know one test, and that is semen test. But you have to think beyond semen analysis because many times semen analysis is normal, and then you have to think of sperm function test. So the sperm function test are the advanced test. सीमेन एनालिसिस के रिपोर्ट में आपको स्पर्म फंक्शन टेस्ट के रिपोर्ट्स नहीं मिलेंगे. तो सीमेन एनालिसिस का रिपोर्ट नॉर्मल हो सकता है, बट व्हेन यू गो इनटू डिटेल्स and if you do sperm function test, then you may find that there is some problem in this male which is the cause of recurrent abortion. And the most famous or the most important sperm function test is DNA fragmentation index or DFI. So sperm DFI, you should know the name of this test. Sperm DFI is the test which will give you idea about the problem with the DNA fragmentation in the sperms, and this will give you idea whether this is the cause of recurrent abortions. Also, you may do genetic testing, you may do chromosome analysis, you may do Y chromosome accumulation, you can do Doppler of the scrotum to see whether there is a varicocele, and you can also do immunological tests like anti-nuclear antibody testing or oxidative stress testing. So all these tests are available, and you should know that these are the tests which you should do. And you should also know that DNA fragmentation index, if it is very high, suppose it is more than 30%, then you have to go for IVF and that to ICSI. Apart from this, the guidelines have also said that lifestyle modification plays an important role in RPL, especially in male partners, because stress, anxiety, smoking, obesity, alcohol are the major cause of recurrent abortions. And one more category which I have found nowadays is becoming more and more common is the young boys going to gym. Now, you will ask me why gym is the cause of abortion or why gym is the cause of infertility. Gym is not a cause of infertility. Gym is not a cause of abortion. These young boys, they are so obsessed about the bodybuilding that they start taking steroids. And this steroid is detrimental to their health. And this is the steroid which is the cause of recurrent abortion. It is also a cause of infertility. The sperm count goes down drastically. So you should tell these young boys, this is a social work which we can do. Tell these young boys that go to gym, do regular exercise, but do not take steroids because they are dangerous. Now, you know that recurrent abortion is one condition which we are discussing today. But apart from recurrent abortions, there is actually a spectrum, and this spectrum starts from infertility, where the patient is not able to conceive, recurrent IVF failures if the patient is going for IVF, recurrent pregnancy loss, which we are discussing today. Before that, there is something called as biochemical pregnancy, where the patient conceives, यूरिन टेस्ट पॉजिटिव आती है और फिर दूसरे दिन पेशेंट को ब्लीडिंग हो जाता है, पीरियड आ जाता है। वो बोलती है सर पॉजिटिव तो थी, मेरी यूरिन टेस्ट पक्का पॉजिटिव थी, 2 लाइन दिख रहे थे, लेकिन दूसरे दिन मेरे को पीरियड आ गया। और फिर डॉक्टर के पास गई तो डॉक्टर बोले कुछ नहीं है। इसको बोलते हैं बायोकेमिकल प्रेगनेंसी। बायोकेमिकल प्रेगनेंसी इज समथिंग विच इज अ पार्ट ऑफ दिस स्पेक्ट्रम। देन देयर आर रिकरेंट abortions. Then there is PIH or pre-eclampsia or gestational hypertension. Then there is IUGR. Then there is oligohydramnios. Then there is sudden intrauterine death. Then there is abruption. And all these things, they are related to each other. Means the patient may present in any of the spectrum in any of the situation. Like patient may present with infertility, patient may present with biochemical pregnancy, the patient may present with recurrent abortion, the patient may present with severe preeclampsia, the patient may present with IUGR, oligohydramnios. So you can get the spectrum, and out of the spectrum, the RPL is one of the factors, one of the part of the spectrum. So the spectrum is a very large spectrum. And there is a very good bit pregnant. Little bit pregnant का मतलब क्या है? Little bit pregnant का मतलब है biochemical pregnancy, UPT positive and abortion. Abortion भी नहीं बोलना चाहिए उसको. Patient starts getting menses and patient is positive and then she starts bleeding. These little bit pregnant patients are frustrated. They say, डॉक्टर मेरा क्या हो रहा है ये, मैं हर बार पॉजिटिव आती हूँ और मेरे को ब्लीडिंग शुरू हो जाता है, मैं क्या क्या करूँ? तो you have to tell her that little bit pregnant is a situation where the chances of pregnancy are more than not having pregnancy at all. So that is how you have to do the positive counseling, because this paper says that if the patient is having biochemical pregnancy, if you treat this patient properly, this patient may conceive in the next cycle. That is what is little bit pregnant. Now, as I told you, history gives you a clue. Like suppose there is a painless second trimester abortion, you know that there is an incombinant os. Suppose there is a consanguineous marriage, आत्ते घरी बच्चे सून, आत्याची मामाची मुलगी, and in that situation, again the chances of recurrent abortions are high. Or suppose there is a classical history, patient gives a classical history of appearance of cardiac activity followed by disappearance. मतलब पहले सोनोग्राफी किया था तो हार्टबीट तो अच्छे थे, 7 वीक्स की सोनोग्राफी 9 वीक्स की सोनोग्राफी करने गए तो हार्टबीट्स गायब हो गए. This is a very classical situation of appearance of cardiac activity followed by disappearance. And in this situation, the commonest cause is thrombophilia or blood may clotting. This thrombophilia is the cause of appearance followed by disappearance. In genetic causes, usually the patient does not get cardiac arrest, usually. So this is the history. So history will give you the clue that where is the problem. Now, starting with the risk factors, the guidelines have clearly said that all the girls should marry early and should plan pregnancy between 20 years to 35 years of age. Very clear. So it is your social responsibility to tell your relatives, to tell your friends that please marry early and have at least one child before the age of 30 years. So we have to take this as a social responsibility. In male partners, if the age is more than 50 years, then the chances of abortion are more. The guidelines also say that stress is not a factor of RPL. Means don't take stress of stress. Stress से कोई recurrent abortions नहीं होते. लेकिन guidelines have clearly said that smoking is a very important cause of recurrent abortion. So you should ask girls especially nowadays. आजकल नागपुर में भी तुम कहीं भी कोई भी ये पब के सामने से जाओ तो वहां पे तुमको 15-20 लड़के लड़कियां मिलेंगी दिखेंगी और वो लड़के और लड़कियां they are all are smoking and this is becoming. I thought that this culture will not come in Nagpur. It is very common in Pune, in Mumbai, but now Bangalore, but now even Nagpur. You go to any pub or you go by the side of any pub, you will find, especially girls, they are smoking regularly. And this smoking is very dangerous. This is a cause of recurrent abortion, something which you all must tell to your patients. Then, as far as the weight is concerned, this is another problem, and it is clearly mentioned that very high BMI and obesity is the cause of recurrent abortion. And therefore, you must tell your patients that please have smart approach for weight reduction. So what is smart approach? Smart approach is specific, measurable, achievable, realistic and time bound program. मतलब क्या कि तुम पेशेंट को बोलोगे कि तुम जाओ 1 महीने में 10 किलो वजन कम करके आओ, तो वो कुछ तो कोई तो डाइट फॉलो करेंगी, किसी से मिलेंगी, ये करो वो करो, कुछ तो करेगी, वो 10 किलो वजन कम करेगी, लेकिन 3 महीने में उसका वजन 20 किलो से बढ़ जाएगा. बिकॉज यू कैनॉट फॉलो दिस फैंसी डाइट्स एवरी टाइम. अल्टीमेटली हम लोग दाल चावल और रोटी खाने वाले लोग हैं. हम लोग ये फैंसी डाइट हमेशा के लिए नहीं यूज कर सकते या नहीं अप्लाई कर सकते अपने रोज की जिंदगी में. सो यू शुड टेल देम टू रिड्यूस वेट बाय 5%, ओनली बाय 5%. Means if the weight of a girl is 80 kg, ask her to reduce her weight by 4 kg in 2 months. That's all. So that is how you have to tell them that reduce your weight by 5%, specific, measurable, achievable, realistic, and timely. This is the approach. And they say that you should ask them to have at least 30 minutes brisk walking 5 days a week. And this is something which they should follow throughout their life along with the diet control. Now, one very interesting point, that can we have multiple causes in the same patient? As we have discussed that anatomical causes can be there, thrombophilia can be there, male partner can be there, but there are some situations where एक ही पेशेंट को दो प्रॉब्लम रह सकते हैं. जैसे हस्बैंड में होगा स्पर्म का प्रॉब्लम और वाइफ में होगा सेप्टम का प्रॉब्लम. So you require a clinical acumen. So you should not stop evaluating the patient if you find one cause. Like suppose you do 3D ultrasound, you find that अरे सेप्टम मिल गया है, सेप्टम तो दिख रहा है, सोनोग्राफी में सेप्टम आया है, इसका मतलब सेप्टम ही कारण है, तो फिर मेल पार्टनर की इन्वेस्टिगेशन करने की जरूरत नहीं है. Don't do that because your clinical acumen will rightly suggest you that there may be two causes in the same patient. Two different causes can cause RPL in the same patient. So DFI is raised in male partner and septum in the female partner. Or maybe chromosomal in the female partner along with the septum. Or maybe thrombophilia in the female partner along with the septum. So you never know. So you should actually evaluate the patient thoroughly. And now coming to the actual causes. As I told you, the first investigation you must do after basic test is thrombophilia. Now, why this thrombophilia is important? Thrombophilia testing is important because it is one of the commonest cause of recurrent abortions. And in thrombophilia, you have to do APLA testing. So what is the APLA testing? ACL, LA, and beta-2 glycoproteins. Only 3 tests: ACL, LA, and beta-2 glycoprotein. There is a APLA test, there is a thrombophilia test, there is a hereditary thrombophilia test, but the guidelines say that you should not do all these tests. You should do only 3 tests, because hereditary thrombophilia test is something which is actually very costly, and there is no need to do this test. That is what guidelines say. So you should do only 3 tests: ACL, LA, and beta-2 glycoprotein. Clear? Then if you have some doubt, then you should actually consult a hematologist, because hematologist is the best person to guide you. Now the guidelines say, and we also do that, we also follow that. What you should do, you should start if there is a thrombophilia positive. Suppose you do the APLA test and APLA test is positive. You should start treatment by, say, लेट्रोज दे सकते हो, क्लोमिफेन दे सकते हो, या बेसिक ट्रीटमेंट चालू कर सकते हो, जिसको हम लोग टाइम इंटरकोर्स बोलते हैं. During that cycle, when you start the treatment, you give aspirin to the patient, because this aspirin, 75 milligram, is going to help her in prevention of clotting. And then, friends, remember this point. As soon as urine test is positive, as soon as urine pregnancy test is positive, start heparin. And what is the dose of heparin? 40 milligram daily is the prophylactic dose of heparin. So if the patient is having a minor problem like APLA positive, start with 40 milligram per day heparin as soon as urine pregnancy test is positive. Do not wait till the cardiac activity appears on ultrasound. कार्डियक एक्टिविटी कब अपेयर होगी? 6 वीक्स पे अपेयर होगी. उसके बीच में 2 वीक्स का क्रूशियल पीरियड निकल जाएगा, जिसमें पेशेंट का अबॉर्शन होने की संभावना बहुत ज्यादा है. इसलिए मित्रों, ये ध्यान में रखो कि आपको हिपेरिन कार्डियक एक्टिविटी आने के बाद शुरू नहीं करना है, यूपीटी पॉजिटिव आने के बाद चालू करना है, तुरंत चालू करना है. मतलब द पेशेंट मिसेस हर पीरियड, urine test is positive, start heparin. Aspirin 1 month before. That is the treatment. That is how you should do. Now there is something called as immunological causes, and as I told you, 40 to 50% patients you don't know the cause. जब cause का पता ही नहीं चलता, तब आपके दिमाग की बत्ती जलनी चाहिए कि शायद ये इम्यूनोलॉजिकल फैक्टर है. इम्यूनोलॉजिकल फैक्टर्स आजकल बहुत कॉमन हो गए, जैसे ऑटोइम्यून डिसऑर्डर्स बोलते हैं, जैसे एसएलई हो गया, या फिर एएनए पॉजिटिव हो गया, या रूमेटॉइड आर्थराइटिस हो गया. इन सब में देयर इज समथिंग कॉल्ड एज TH1 एंड TH2. TH1 TH2 जो है टी हेल्पर सेल्स, दिस टी हेल्पर सेल्स आर का सब खेल है, जिसके कारण अबॉर्शंस होता है. TH1 जो रहता है, TH1 इज एक्चुअली रिस्पॉन्सिबल फॉर graft rejection. Means TH1 is not good. TH1 leads to graft rejection, and TH2 leads to implantation. So if there is a imbalance between TH1 and TH2, then the abortion will take place. That means, in short, जब विनाशकारी शक्तियां अच्छी शक्तियों पर हावी हो जाती है, तब अबॉर्शन होता है. TH1 की जो विनाशकारी शक्ति है, वो जब TH2 की अच्छी शक्ति के ऊपर हावी हो जाती है, तब एक्चुअली abortions होते हैं, recurrent abortions होते हैं. So this is a very simple thing which you all should remember. And this TH1 TH2 जो रहते हैं, इसके लिए there are many tests which are available. And the immunological tests which are available are antiphospholipid, we have discussed that. Then there is antithyroid antibody, anti-gliadin antibody, anti-sperm antibody, anti-nuclear antibody, and anti-ovarian antibody. So all these anti-ovarian antibodies, these are the investigations which you can do. All these are the autoimmune disorders, and autoimmune disorders can be a cause of recurrent abortion. But at the same times, guidelines say that you should not do very advanced tests like NK cell testing or HLA testing. You should not do all these tests. Now, the most important part for us, we all are gynecologists. We all are examining our patients day in and day out, and we cannot imagine life without ultrasound. I cannot imagine life without ultrasound, because ultrasound is something which is becoming, a magical tool to investigate a patient. And in that ultrasound, it is a 3D ultrasound which is going to help you, because 3D ultrasound will give you such a wonderful picture that you can actually see this is a normal cavity, this is a unicornate uterus, this is the bicornate uterus, this is a septate uterus, this is a diadelphys uterus, this is complete two parts of the uterus. So you can actually T-shaped uterus. So you can actually diagnose the condition, the anatomical causes of recurrent abortions very nicely with 3D ultrasound. No need to do laparoscopy. Laparoscopy is now not anymore a gold standard investigation. Laparoscopy always comes as second line investigation. पहला इन्वेस्टिगेशन कौन सा है? 3D अल्ट्रासाउंड. और 3D अल्ट्रासाउंड इतना सुंदर है कि आपको लैप्रोस्कोपी की जरूरत ही नहीं पड़ती काफी बार. ऑफ कोर्स यू कैन यूज लैप्रोस्कोपी फॉर ट्रीटमेंट बट नॉट फॉर डायग्नोसिस 3D अल्ट्रासाउंड इज सफिशिएंटली गुड. एंड सो इफ यू गेट सेप्टम, आज ही सुबह मैंने एक सेप्टम रिसेक्शन किया. Septum resection is something which gives you wonderful results. So you have a septum, you cut the septum and you get the results. Then if you are having some problems like fibroid, adenomyosis, then you can treat the patient by removing the fibroids or by doing treatment of the fibroids. One more surgery which I do very regularly is laparoscopic interval encerclage. What is this laparoscopic interval encerclage? This is the Marcelin tape. And this Marcelin tape we are using for encerclage with the help of laparoscope when the patient is not pregnant. So suppose the patient comes to you with history of 3 abortions. All 3 abortions are second trimester, 18 हफ्ते का, 18 weeks, 20 weeks, 22 weeks, painless second trimester abortions. You know that there is some problem with the cervix. And this cervical problem can be treated with interval laparoscopic encerclage, which is a wonderful surgery. We have done 9 patients in last 1 year, and 1 year 9 patients we are getting excellent results. Almost 6 patients have now conceived and they are doing very well. Touch wood, they are doing very well. So this is all because of the laparoscopic interval encerclage, the surgery which I have been doing since last so many years, and it is a rewarding surgery, and I am very happy because we are getting very good results with this laparoscopic interval encerclage. Then what about the endocrinological test? Endocrinological tests are the tests which we all do regularly. We do FSH, we do LH, we do prolactin, we do thyroid, we do AMH also. And we cannot think of, treatment is अधूरी रह जाएंगी यदि हमने ये टेस्ट नहीं किए तो. So you have to do all these tests, but the guidelines have said that the most important test is thyroid test. And not only thyroid testing, they say that even anti-TPO antibody, which is the immunological test, anti-TPO antibody should also be done in all the patients of recurrent abortion. So thyroid testing is very important. They have said that AMH is not very important. FSH is not very important. But what is more important is thyroid testing along with anti-thyroid antibody testing. But we do all the tests. We do tests because we know that if there is a problem with the ovarian reserve, suppose patient को PCO है या patient का AMH बहुत low है जिसको हम लोग diminished ovarian reserve बोलते हैं, तो we are treating such patients, and if you treat these patients you sure get the results. So therefore this is something which we all do and we must do. Then all-time favorite, we all treat our patients with luteal phase support with progesterone, and progesterone is something which we all give, and even guidelines say that you can give progesterone as a luteal phase support. Not only that, we give metformin in PCO patients, we give DHA in DOR patients. So all these drugs are important. They are given regularly in our day-to-day practice. Now, what about torch test? This is a very controversial issue. Why controversial? Because still I see many people doing torch testing in RPL, patients of RPL. Friends, remember, very clear, RIP Torch. Torch, rest in peace. There is absolutely no role of torch testing in recurrent abortions. You have to remember this point strongly, because I have seen many doctors doing torch test for recurrent abortions. Now, why torch testing is not required? Because if the patient is having infection and IgG positive रिपोर्ट आया तो इसका मतलब पेशेंट को एंटीबॉडीज ऑलरेडी डेवलप हो गए, तो she is already getting the protection. And if IgM is positive, then that IgM positive is the active infection or the acute infection which is the cause of problem in that particular period. जिस वक्त IgM positive रहेगा, रूबेला positive है समझ लो, टॉक्सोप्लाज्मा positive है, तो at that time when it is positive it will create problem, but it will not create a recurrent problem. After 1 year it is not going to have any problem. So torch test is not advisable and it is not advised in the investigations of recurrent pregnancy loss. This is very clear, and you all now know that fraud should not be done. Now I am doing IVF. I am doing IVF since last 20 years, and I am running my hospital since last 30 years. 2005, 6, 2005 we started IVF, and now since last 10 years, we are regularly doing PGT or pre-implantation genetic testing. I've told you about PGT. Now, what is PGT? Suppose a patient comes to you with recurrent abortions, and you know that there is a problem in the chromosome, structural problem in the chromosome. You do PGT and you do the testing of the embryo. So, before putting the embryo inside the uterus, you are selecting the best embryo. Now you know that this embryo is good, there is no genetic problem, and this is a healthy embryo. So you are sure that this patient is not going to have develop recurrent abortions, or she is not going to develop abortion in the future in this pregnancy, because you have done the PGT and you have transferred the best embryo. So PGT is something which is actually becoming very popular. आणि आजकाल माझ्याकडे मराठी समझता है ना आप लोगों को कि कोई हिंदी वाला भी है?
हाँ हाँ बिल्कुल सर.
हाँ, तो
सारे
आज
मतलब they are from all over India, from different states.
so I
So
prefer talking not talking in Marathi. So आजकल हमारे यहाँ, so what I was telling you is आजकल हमारे यहाँ हर महीने में हम लोग 100 पेशेंट्स करते हैं. 2-3 पेशेंट हर महीने में पीछे करते हैं. और
okay.
there are many doctors specially, or many IT professionals, educated people, if they are planning pregnancy around the age of 40 years, then we do PGT in these patients. Because with PGT, we are selecting the best embryo, and therefore chances of abortion are very less, and the chances of even congenital abnormalities are also very less, and you get the best embryo for the transfer. So that is what is PGT. A very important question is, what about empirical treatment? जैसे कभी कभी situation arises that you don't know any cause, you don't find any cause, you investigate the patient, you do all the tests, and you realize that there is no cause, it is idiopathic. So कुछ तो देना पड़ेगा, नहीं तो पेशेंट बोलेंगे डॉक्टर ने हमको कुछ ट्रीटमेंट ही नहीं किया, ठीक से बताया नहीं क्या हो रहा है, हमको कुछ समझ भी नहीं आ रहा. अब हम क्या बताएंगे जब हमको खुद को ही पता नहीं कि क्या प्रॉब्लम चल रहा है. बट इन दैट सिचुएशन there is a role of empirical treatment. What is empirical treatment? Treatment which we give empirically when we don't know the exact whether this treatment is going to work or not, but still we give it. Here, the guidelines are very clear that you should not give empirical treatment, and especially you should not give heparin. But friends, here I agree to disagree. I am really sorry for these guidelines, but I and all doctors or many doctors, they actually give heparin empirically. And why I'm telling you this? Because you have to give solution to this patient. And if you give heparin, if it works, and if the patient conceives and continues her pregnancy till 9 months, then you are also happy and she's also happy. So ultimately, you have to give something, give some solution to this patient. And though the guidelines say that strongly that you should not give heparin, we all give heparin, and I think we will continue giving heparin because we want results, and ultimately we want take home baby, healthy baby. As far as the other treatments are concerned, progesterone we all give and we must give to this patient. Vitamin D and folic acid, it is said, is good. So we should give folic acid to all patients, vitamin D and progesterone to all these patients. And then we do the actual treatment.
Sir, which kind of progesterone do you select? Means orally, locally, which have a greater impact in early pregnancy?
It's a separate chapter, but I must tell you that vaginal progesterone is considered as the most preferred mode of progesterone administration. Vaginal progesterone is most preferred, but dydrogesterone is the drug which is becoming very popular day by day, which is an oral. Dydrogesterone is an oral progesterone, and it has got a good absorption. Therefore, it is becoming popular. So you select either vaginal progesterone or a dydrogesterone, which is an oral progesterone. But oral progesterone, the absorption is less as compared to vaginal progesterone. Vaginal progesterone has got a direct action, and because of the direct action, vaginal progesterone works very well. So you should always give preference to vaginal progesterones over any other progesterones. Okay? So we start with the treatment then, and we do the treatment of RPL in a similar fashion. Like we do time intercourse टू आवर पेशेंट्स अपन बोलते हैं कि हमको टाइम इंटरकोर्स का ट्रीटमेंट चालू करना पड़ेगा. देन यू गिव लेट्रोजोल टू द पेशेंट, you give support to the patient, you give progesterone, you give HCG, progesterone, and the patient can conceive in this situation. You give aspirin also because the guidelines say that you should give aspirin 1 month before. So you give all the cocktail, पूरा मसाला हम लोग पेशेंट को देते हैं, and the patient may conceive. Then if still the patient does not conceive, तो हम अपना ब्रह्मास्त्र निकालते हैं. ब्रह्मास्त्र क्या है? IUI करके देखो, या उससे भी नहीं हुआ तो IVF करो. So this is how we start the treatment with time intercourse and may go for IUI or may go for ब्रह्मास्त्र, that is ICSI. अब कैसा है कि कुछ तो लोग कहेंगे लोगों का काम है कहना, क्योंकि आप पेशेंट को ट्रीटमेंट कर रहे हो तो आपको सवाल तो लोग करेंगे और सवाल का जवाब तो आपको देना पड़ेगा. अब पेशेंट भी बहुत होशियार रहते हैं. दे आर वेरी स्मार्ट बिकॉज दे आर रीडिंग नाउ डेज, दे आर डूइंग Google and then read, then they have so much of knowledge, there is no dearth of knowledge. So they will ask you, doctor, मेरा प्रॉब्लम प्रेगनेंसी नहीं रहने का नहीं है, मेरे को प्रेगनेंसी तो रह रही है, मैं प्रेग्नेंट तो हो रही हूँ, लेकिन मेरा प्रॉब्लम एबॉर्शन का है. तो मेरे को यदि एबॉर्शन हो रहा है तो आप मुझे ये टाइम इंटरकोर्स का ट्रीटमेंट क्यों दे रहे हो, या आप मेरा आईयूआई क्यों कर रहे हो, मेरा आईवीएफ क्यों, मैं प्रेग्नेंट तो रह जाती हूँ. I have no problem with conception. The problem is not with the conception. The problem is with the continuation of the pregnancy. So how this treatment is going to help me? So you should be able to answer this question. And the answer is very simple. The answer is, when you conceive, you have to tell this to your patients. See, when you conceive and you come to me in my clinic at 6 weeks of pregnancy, when UPT is positive, you do your urine test at home and then you come. खुशी खुशी से हम आते हैं कि डॉक्टर साहब मेरे को प्रेगनेंसी रह गई, मैं प्रेग्नेंट हूँ, अब आप इलाज करो. बट यू आर नॉट टेकिंग एनी सपोर्ट, you are not taking any treatment during the previous cycle when the conception is actually taking place. You know that there is implantation window. You know that on day 14 the ovulation takes place. You know that at day 21 or day 20 the implantation takes place. You know that implantation takes place, then after 10 to 14 days you do urine test and then it comes positive. What about this period? The period of implantation, the period of conception, the period of fertilization. This is the period which is not at all treated. So you have to tell them that when we do time intercourse, when we do IUI, when we do IVF, we start the treatment much earlier. Sometimes 3 months before we start treatment. We start folic acid 3 months before. Patient को PCO है तो we start metformin 3 months before. We give antioxidants to your patient. So then we start a treatment, and then as we have discussed in guidelines, we give aspirin to the patients. All this is going to help her in continuation of pregnancy. That should be your answer. And therefore, but at the same time, tell them कि मैं गारंटी नहीं ले सकते, हम गारंटी नहीं ले सकते, क्योंकि गारंटी तो सिर्फ भगवान ले सकता है. हम सिर्फ मेहनत करने वाले लोग हैं, हम मेहनत करेंगे, फल तो ईश्वर देने वाला है. So that is how you have to convince them that this treatment is important. And then, as I told you, your convincing power is important. And grief counseling, the way you counsel your patient is extremely important. That is called as tender loving care. And TLC is something which has got a great role to play in the patients of recurrent abortions. क्योंकि recurrent abortion के patient इतने निराश हो जाते हैं कि उनका डिप्रेशन जो है, it is like impact of a death of a near one. They are so depressed, so frustrated, that it is like a death of a near one. And these are the patients who need special care. So you have to give them time, you should talk to them, and you should counsel them that this happens. Don't worry, I am going to treat you, I am going to take your special care of your case, and I am going to see to it that you conceive and you go home with a healthy baby. That is what you have to counsel them. And so you should be very good in counseling, and TLC is something which is important. So now this is the last slide. And this last slide is going to give you the algorithm of whatever we have discussed till now. So this is the take home message. Suppose the patient comes to you, सबसे पहली बार, with a report of missed abortion. The first thing you do is do the chromosomal testing of the products of conception. So you get the direction. दिशा मिल जाती है अपने को, हमको क्या करना है. Then next is you do ultrasound, very important. Then you do antiphospholipid testing, very important. Then you do thyroid testing, very important. So this said that thyroid test must be done. Then what about genetic testing? Genetic testing can be done if required. Like chromosome analysis of husband and wife, you do if it is required. Then what about immunological test? There is no need to do this test, but you can do this test in special situations by taking the expert opinion of immunologist or immunotherapist. Then you should do another test of husband, that is sperm DNA fragmentation test, which is an important test. Then the guidelines say that don't do AMH, don't do FSH, don't do LH, but I will tell you that you must do this test because you should know what is their ovarian reserve. You should know whether the patient is ovulating or not, what is the quality of oocytes, क्योंकि इसमें quality of oocyte का भी एक बहुत important role है. So the oocyte quality you get idea from the FSH, from the LH, from the AMH reports. So do prolactin, do FSH, do LH, do AMH, and also do thyroid testing. So all these tests are important. Do all these tests and then try to find out the cause, treat the cause, and then only ask the patient to conceive. And finally, कर्मण्ये वाधिकारस्ते मा फलेषु कदाचन. कर्म करते रहो, फल की आशा मत करो. This is the philosophy of life, and same is the philosophy of a medical treatment for all. We all are practitioners, we all are day to day doing our job, but when we do your job, when you do your karma, कर्म करते रहो, फल की आशा मत करो. This is the philosophy of our treatment. Thank you so much. Thank you, Archana. Thank you, everyone, for giving me this wonderful opportunity. Thank you.
Excellent webinar. It's point to point, and every point clearly you have mentioned, sir. And I really pleased to hear you every time. Even last time also, I was like, oh, wow, it's too great. Means whatever the practical approaches that we need when the patient come in your OPD, you means in your speech or your webinars I have seen, it's absolutely like free of mind. Yes, just do this is a specified one, and very in easy way you interpret such a difficult topic in a simple way. Just fabulous.
Thank you so much. Thank you.
Dr. Archana, you
Ma'am,
can take the question or the
yes,
query
ma'am.
regarding.
Yes, ma'am. Thank you so much, sir, for this wonderful talk. Actually, sir is so friendly कि आप जब first time मिलेंगे हैं sir को, तो sir is like बाप रे मैं sir को कितने बार मिल चुकी हूँ. So and sir का same behavior is with the patients also. So patients are very comfortable, and also we are also review. I have worked with sir also. Sir is very friendly, and the last like tender loving care. So this is very true with you, sir. You love the patient, you take care of the patients very much, and I think the reason is that the patients are very much connected with you. Thank you so much for giving precious time for us, sir. We'll be starting with the question answer session. I request Dr. Aarti
Take the
answer session. Dr. Aarti.
Thank you, sir, for this wonderful session. So we have a question like, if torches is not now working, then why all doctors to rubella IgG and give vaccine if IgG is negative? Should we continue this or not?
I think we should give rubella vaccine. And I will give you a very practical solution. The practical solution is that why you want to waste your money in doing rubella testing? Why can't you give rubella vaccine to all your patients? So instead, because rubella vaccine is very cheap, RVAC, I don't know what is the cost, but it must be around 400 rupees. I don't know. Archana, what is the cost? Around 400, 600? It is very cheap. So instead of doing the test, you can give rubella vaccine to all your patients. But you have to tell them that if you have received rubella vaccine, then you should not conceive for 3 months. Right?
Okay, sir. So we have next question. If
आवाज आ रही है
partial
मेरी?
mole or the complete mole is the cause of RPL, then what management we have to do? Sir, is it audible?
एक minute. I think there is some problem with the voice.
Yes,
I'll
sir.
try to. I think internet is not stable, so I'll just check. Yes. Now can you?
Yes, sir.
Are you getting my?
If partial, yes, sir. Yes, sir. Is it audible, sir? Now,
Yes, tell me.
if partial mole or the complete mole is the
Yes,
reason
yes,
for
बिल्कुल.
if partial mole or complete mole is the reason for RPL, then what are the management?
See, vesicular mole is altogether a different topic. And if the patient comes to you with vesicular mole, whether it is a partial mole or a complete mole, then you have to investigate this patient in a different way. So I would suggest you to go into the details of vesicular mole and investigate this patient, do genetic testing as well, and then you can start the treatment. But in vesicular mole, the treatment and investigations are different because you now know that this is not a patient of abortion, it's a patient of vesicular mole. So vesicular mole is a altogether a different or a separate topic. But then you have to evaluate this patient at the same time.
Okay, sir. So we have next question. Like after cervical cancer vaccine, how long we should avoid pregnancy?
Actually, you need not avoid pregnancy if the patient has given the received cervical vaccine or if you have given cervical vaccine to your patients. There is no need to avoid pregnancy at all. Like in rubella, we wait for 3 months. In cervical vaccine, there is no need to wait for 3 months also. But it is said that it is better to avoid pregnancy for 3 months. But then, if the parent has conceived and she has received cervical vaccine within last 15 days or 1 month, it is not going to have any impact on her pregnancy and you can continue with her pregnancy. But at the same time, during pregnancy, you should not give her next dose of cervical vaccine. You can postpone the cervical vaccine dose. Suppose you know that there are 3 doses of cervical vaccine. If you have given 2 doses and the patient is conceived, then you postpone the third dose and give it after pregnancy. But there is
Okay, sir.
no harm in continuing pregnancy even if the parent receives cervical vaccine.
Okay, sir. So we have another question in the chat box. Like if TSS level is normal, then whether it is necessary to do anti-TPO testing.
A very good question. And this is the question which I always ask to all my endocrinologist friends that how do you decide when to do anti-TPO testing? Because many times TSH is normal and anti-TPO is positive.
Okay.
And TSH is abnormal and anti-TPO may be positive. So what the guidelines say and what we follow is in all patients of recurrent abortion, we do thyroid testing and anti-TPO both. And if the anti-TPO is positive and TSH is suppose high, then we give, of course, thyroid treatment, that thyroxine or whatever treatment is advised. But if the thyroid levels are normal and anti-TPO is positive, then there is no role of thyroxine. Then what treatment we give? We give treatment in the form of maybe steroids or immunoglobulins, the treatment of immunological treatment of the autoimmune disorder. We don't give thyroid in this patient, but if the patient is having hypothyroidism, then we give the treatment of thyroid also. So ideally, irrespective of thyroid testing, we should do anti-TPO testing in all the patients where we are suspecting autoimmune disorder or where we are suspecting immunological cause as a cause of recurrent abortion.
Okay, sir. So we have next question. Can we use low dose aspirin and heparin together?
Yes, aspirin heparin it should always be given in combination. It is the aspirin plus heparin combination which works wonders, and therefore you should give aspirin and heparin in combination. But if the patient starts bleeding, like this is what happens many times, that patient is bleeding, then you should stop both. In such situations, what I do and what many of our friends IVF consultants do, suppose the patient is having problem where you have to give aspirin and heparin and the patient starts bleeding because of the aspirin and heparin combination. Then you stop both for 3 to 5 days. Then you can start with heparin and stop aspirin. Because if there is a thrombophilia and if you don't give aspirin and heparin both, then the patient will have clotting and the patient will have missed abortion. So you have to select one out of two, and in that case, you should give heparin, which is a preferred drug over as.
Okay, sir. So we have another
But
question.
ideally, you should do
Like,
both.
okay, sir. So which
Yes,
month we
yes.
have to do? Which month we have to do this cervical encirclage if we have second trimester recurrent abortion?
Cervical encirclage, if the patient is pregnant or if she has conceived, then it should be done ideally at 14 to 16 weeks of pregnancy.
Okay, sir.
14 to 16 weeks.
Okay, sir. So what are the precautions we can do to avoid like recurrent pregnancy in this era?
No, my question is actually
Acha,
different.
I think
Is there
the
any
question is
role of
something like
ERA in
something
RPL?
era,
ERA is
okay.
endometrial
Era is
receptivity array,
endometrial receptivity array.
which
Yes, ERA
actually
is one of the
I
symptoms.
have practiced in Europe. So whether sir is practicing here also, that I wanted to know.
We do ERA. We do ERA. In see, if the patient is having recurrent abortion or recurrent implantation failure, then ERA is one of the options which can be given. Now, what is ERA? ERA is actually the personalized window of implantation. So we do a testing of the endometrium. In one cycle, before the IVF cycle, we do testing of the endometrium and we find out whether you are giving the right progesterone at the right time. So they will suggest you that you are not giving progesterone at the right time. You should give progesterone early or you should give progesterone late. So what is ERA? ERA is a test which will give you idea about the implantation window of implantation, and whether your window of implantation is correct or not. Yes, we do ERA in our day-to-day practice, but not very commonly. We do it rarely because nowadays there is a controversy about ERA, and many guidelines they say that ERA is of no use, and therefore ERA is one of the options which we give to our patients. Cost around 35,000 rupees. So we give them option. If you want, we can do this ERA testing. Remember one thing, friends, that all the investigations, any investigation you do, these investigations are not going to have any impact on the treatment as far as the treatment is concerned. Like, see, it is not going to harm you. तुमने एक ब्लड सैंपल लिया और टेस्ट किया तो उससे तुम्हारा कोई नुकसान नहीं होने वाला है. नुकसान सिर्फ तुम्हारे खिस्से को चोट बैठने वाली है, तुम्हारे पैसे का नुकसान होने वाला है. लेकिन वो टेस्ट का इंटरप्रिटेशन करना बहुत इंपॉर्टेंट है. सो यू शुड बी एबल टू इंटरप्रेट द टेस्ट प्रॉपरली एंड देन ट्रीट द पेशेंट अकॉर्डिंगली. So ERA is one test which is not very commonly done but can be given as one of the option to see whether the embryo is put in the uterus at the right time. Window of implantation.
Sir, thank you. And what about lipid installation? Are you using that also?
Intralipids we are regularly giving to all our patients because intralipid is said to reduce the NK cell levels which are responsible for the rejection of the graft or the abortions. So NK cell is like TH1. It is TH1. It is immunological factor which is responsible for the rejection of the graft. So graft rejection can be treated by giving intralipid. So intralipid is one of the. It is an empirical treatment. Remember, friends, it is not a. It is not intralipids is not given. It is a. It is actually a total parental nutrition. So TPN we are giving in this patient for reducing the NK cells. So it is not a confirmatory treatment. It is an empirical treatment.
Thank you. Thank you.
So we have next question. Should aspirin be started after UPT positive or prophylactically in preconception period in patients of RPI?
As should be given prophylactically. And heparin should be started after the pregnancy is positive. 1 month before you should start aspirin.
So we have next question. So what are the success rates of expectant management for recurrent pregnancy loss?
Success rate is definitely good. It depends upon your clinical acumen. Basically, it is the clinical acumen which is important. So you should know which treatment should be given in which situation. If you know this, then you will get the success. So the success rate is good if you do the proper testing and treat the patient in a proper way. Here you have to use your clinical acumen, your experience, your expertise.
Yes, sir.
Yes, what is the next question?
Yes. So, what is best to give, progesterone, duphasтерone, or hydroxyprogesterone, which is better?
As I told you, vaginal progesterone is really good because vaginal tablets definitely are good for absorption. Second is oral, dydrogesterone. Injectable progesterone, yes, hydroxyprogesterone caproate is something which can be given. We also give this injection because it's a depot injection. It can be given once or twice a week. But the problem is it is very painful because it is an oil-based injection. So you have to give it carefully. You should avoid it in very thin patients. You should avoid it in patients with diabetes. And you should give it up to 12 weeks of pregnancy, not beyond 12 weeks of pregnancy. But the
Yes,
best is
sir.
vaginal progesterone.
So, we have one more question. Like, should we start one progesterone or two duphaston 10 mg or sustain 300 mg also given? So, how to decide one or two to give?
The standard dose of oral dydrogesterone is 10 milligram TDS in IVF patients and 10 milligram BD in IUI patients. So simple treatment 10 milligram BD is the standard dose, and in IVF patients 10 milligram TDS is the standard dose. Standard dose of vaginal progesterone is 200 milligram to 300 or 300 milligram in patients with simple treatment and 400 milligrams in patients with IVF. So 300 milligram is the dose for simple treatment and 10 milligram BD is the oral dose for simple treatment. So that is what, depending on the situation, IVF करना है कि simple treatment है कि IUI. Simple treatment में dose कम रहेगा, IVF में ज़्यादा रहेगा.
Okay, sir. So, we have one more question. Like, do you recommend Lodin tablets?
Iodine.
Iodine.
Iodine, sorry.
Iodine. So iodine tablets, I never use iodine tablets actually. I don't know, but then there are many.
So there are, sorry to interrupt you. I'm Dr. Sharyu Vankade. Actually, I have practiced in EV, Valencian Institute of Infertility, Europe. I was doing their IVF with oocyte donation and all. So there is one tablet, the name is Yodu. And I actually conceived in my pregnancy also in Europe. So that is my forbidden fruit in India to treat my patients. So here comes Yodo Plus. The name is Yodo Plus in India. It is available right now, and that is iodine tablet. And I think it will correct that the anti-TPO what you have told right now. So maybe it will take care at some level. And because I used to start that from the first consultation to my all patients, and it gives some positive results in conceiving and to continue the pregnancy. So I
Sir,
think
this is a good take-home message.
hmm.
As Sarah she is sharing her own experience, and I must tell you that we do take the opinion of endocrinologist. We do not take this decision, but what Dr. Sharif is telling is right. There are many preparations which are available in market. They contain iodine, and iodine is given in many situations in patients with recurrent abortions. So definitely this is something which can be tried.
And second thing, actually, so do you come across with absent nasal bone right now? Because nowadays it is very common, I think, absent nasal bone in 12-week pregnancy. And if yes, then what may be the cause you think? Miss, I want to know your opinion that after corona, it is very common, or it is fineness of USG sonography that it is because of that, maybe?
No, it has nothing to do with corona because the absent
Mhm.
nasal bone is something which is suggestive of Down syndrome, right? And Down syndrome is something which is a genetic deformity. And this genetic deformity is a sporadic deformity. So what happens what is happening is nowadays the incidence of all the problems is rising. Uh, yes, definitely ultrasound is now so advanced that you can actually detect very small defects on ultrasound. But at the same time, the only absent nasal bone is not going to have its impact, and only absent nasal bone is not does not mean that you should do abortion, but you should investigate this patient. You should
We
do
should.
with the
Yeah,
chromosomal
this
testing.
is.
Either you can do
Mhm.
disease, or nowadays NIPT is also one option
Mhm.
is available. Do NIPT, do disease, and confirm that this
Mhm.
absent nasal bone is not or is associated with Down syndrome. If it is associated with Down syndrome, then you have to do the abortions. But
Yeah.
what you are saying is very true, that the incidence of genetic deformities is rising day by day, and we don't know the cause, but it is rising.
So you also come with
Sir,
across this type of
Very
test.
high, very high
Okay.
incidence.
Okay.
sir, as we
Thank
were
you.
talking
I
about
just want.
the genetic disorders, can you please elaborate with the PGS and the PGD?
Yes, there is something called as pre-implantation genetic testing, and initially it was PGS and PGD. Now, what is PGS and what is PGT? The terminologies now change. Terminologies now change, and we now call it as PGTA and PGTS. Though, so if PGT, what is PGTA? It is PGD. Sorry, PGS. PGS is now PGTA. So pre-implantation genetic screening is now PGT. A means aneuploidy. So what we do is we actually do the pre-implantation genetic testing, and we find out whether there is a Down syndrome or aneuploidy. So PGTA is for aneuploidy, which is also called as PGS. So what we do is we try to find out whether the patient is having a problem which is not recurrent, but it is actually a, a sporadic problem. किसी में भी कभी भी हो सकता है. तो यूजुअली क्या होता है कि इफ यू हैव अ पेशेंट हु इज अराउंड 40 years of age, then you do
Mm-hmm.
then you do PGT,
Okay,
because
but like
PGTA.
other disorders like sickle cells and which is
हाँ,
means
for that
coming
you
from
do,
the
yes, for that you have to do PGTM.
okay.
So specific testing is PGTM, and screening is PGTA
Okay.
or PGS.
Okay.
PGT is PGT
Mm-hmm.
for specific problem like sickle cell. It is PGT, and
Yeah.
general testing
Yeah.
like suppose patient is
Okay.
of
Fibrocystic diseases,
so
sickle cells,
40,
yeah.
40 years is suppose a patient comes to you with 40 years age. She is 40 years, so the chance of Down syndrome is high because her age is more than 35. Now in that situation, what will you do? You'll do PGTA or PGS, aneuploidy testing.
Okay, sir. Okay.
So we have next question, like 3D USG showing poor endometrial blood flow. How to proceed in such patient?
Study
There
of
is
children.
yes, there is something called as Applebaum scoring. Applebaum scoring actually uses Doppler. It is not 3D, but it is a Doppler which is used. And in Doppler, you actually put the blood, color Doppler, you put the blood. We do power Doppler. कलर डॉपलर पेक्षा सुद्धा ज्यादा इंपॉर्टेंट क्या है? पावर डॉपलर. आजकल कलर डॉपलर यूज करते हैं प्रेगनेंसी में, पावर डॉपलर यूज करते हैं गायनिक में. तो पावर डॉपलर में हम लोग पावर डॉपलर डाल के मतलब कलर डाल के देखते हैं, एंड वी सी द एंडोमेट्रियल ब्लड फ्लो. If you find that endometrial blood flow is not good or not proper, in Applebaum scoring, there is a great zone of blood supply, zone 1, 2, 3, 4. Zone 4 is the best, zone 1 is the poorest blood supply. Then you can actually start aspirin in such patients. And aspirin definitely helps in such patients to increase the blood flow. We also use Viagra or sildenafil, which is actually a vasodilator in such patients. We also give heparin in some situations to such patients, depending on the problem.
Thank you, sir. Any more questions anyone want to ask?
Sir, one last question actually. Do you prefer blastocyst transfer or how? And if yes, then do you go for single embryo, single blastocyst or how?
Yes, we nowadays do only blastocyst transfer. We don't do levastrous transfer. We do blastocyst transfer, provided we get good number of embryos. So we always put blastocyst. Nowadays, we have started putting even one embryo, but usually we put two embryos. So normal trend in India is to put two embryos. Blastocyst two embryos, but sometimes, like suppose everything is good, good endometrium, good blood supply, young patient, even one embryo is also good. Or nowadays many patients come for second pregnancy, they already have a child, then we put only one embryo. So single embryo transfer also we do in many situations, but most of the times we do two embryo transfers, and that to blastocyst.
Sir, which parameters you prefer actually means that as we say endometrial era or era we are not doing nowadays, but which are the other parallel parameters that we used to do, like for the ovum factor, for the endometrial factor, usually for means blood testings or other things, which are equally will give us the idea that yes, it is a good one and we can go further for this treatment.
Actually, I personally feel that you should and you need not do very fancy investigations.
Yes.
You should actually stick to the basic investigations, and you get a very good idea about the ovarian reserve by doing FSH and AMH and FSH. You
Yeah.
get a very good idea about ovarian reserve by doing ultrasound, which is called as anterior follicle count, AFC.
Yes.
If you do ultrasound day 2 of menses, you get to know about the ovarian reserve. Ovaries में कितने follicles है, anterior follicle count तुम कर सकते हो, and it gives you a very good idea about the ovarian reserve. Suppose you think that there is a problem with the endometrium, you do ultrasound, you find that there is a say calcification or calcified spot, or you see that the endometrium is very bad, you think of tuberculosis. If the blood supply is very poor, you think of tuberculosis or infections. So ultrasound, basic blood test, proper clinical acumen is sufficient for the proper management of a patient.
Sometimes that we found some fluid in the endometrial cavity for the,
Fluid in the
specifically some
endometrial
IUI.
cavity is something which has got a very good, very important significance. If there is
Yeah.
a fluid in the cavity, it can be because of the infections. But at the same time, sometimes there is a small fluid which is seen linear fluid or linear hypoechoic shadow which is seen in the ultrasound which disappears later on. So if it is a linear shadow, it has to be ignored. But if there is a fluid which is irregular and it is collection in the cavity, then mostly it is because of the infections. And then you should give antibiotics to this patient. And not only antibiotics, we also give steroids to these patients. We give Visolon tablet. Steroids also we give along with antibiotics.
Okay, sir. So, Aarti, is there any more questions?
No, ma'am. If anyone wants to ask any more questions. Okay. Thank you so much, sir, for this wonderful session and wonderful knowledge what you have shared with us. So on behalf of NIMA OBGY Society Central, I express my gratitude to OBGY President Dr. Kamini Diman ma'am, Secretary Dr. Priyanka Nakade ma'am, Treasurer Dr. Vishnu Bhavne sir, and Convener Dr. Rajesh Uttane sir. I also like to thank our eminent speaker Dr. Shembikar sir, who took time from his busy schedule and delivered this lecture. I would also like to thank our technical team, Akash sir and Prajakta ma'am for coordinating this webinar. Last but not least,
I think there is some network issue. Dr. Archana, please conclude.
Yes, sir, thank you so much, sir, for giving your precious time for us. It was really treat to hear you, sir. I had few queries, but it was all solved with your detailed and very detailed presentation, sir. It was explained very clearly to us. So, many of my queries were solved, and your presentation was very knowledgeable, sir. Thank you so much. And we'll look forward for again hearing you back on our platform, sir. Thank you so
Sure.
much, sir.
Thank you, Archana. Thank you so much. Bye bye.
Just
Thank you.
want
Thank you, everyone.
I just want to highlight one thing that first of all I want to congratulate you, sir. That is it's a really feast for our brain, and I just wanted to tell all the person that there are two take home messages that we should treat a patient after first abortion. That is very well said by sir. And second thing, I like that statement very much, that I agree to disagree. So that is really important, because sometimes we don't have any rational reason to give some medicines or advice to the patient, but we have to. And that yes, eventually that advice is came because of our last year's practices, that our experience, that we have treated so many patients, and that is really important for those patients. So we have to agree to disagree. That is a very good statement. I think we should remind these two sentences well. And thank you, sir, again for the beautiful presentation. Thanks a lot.
Thank you. Thank you, everyone. Thank you, Archana.
People are asking for your number also.
Dr. Priyanka, thank you so much.
Yes, sir. Shall we give your other numbers? People are asking for your number.
Yeah, you can give number, no problem, absolutely no problem. And if I don't answer the call, you can WhatsApp
Yes.
because
Yes, definitely.
you can-
Definitely, sir. Thanks a lot.
Thank you so much.
Thank you so much.
Sure.
Bye, Archana. Bye. Bye.